I would like to introduce Dr. Stefan Weber-Karsten. He is a doctor working in the Charité in Berlin, in Germany, at the Department of Anesthesiology and Intensive Care Medicine. And Dr. Weber-Karstens is going to talk about ventilation of patients with injured lungs, in particular those with ARDS.
In the following 30 minutes, I want to give you an overview about the basics in ventilating injured lungs, with a specific focus on ventilating and treating ARDS patients. We will go over about the general mechanisms how mechanical ventilation can cause harm in these patients, and with respect to this knowledge, how to set up a lung protective ventilation in these patients. And at the end of the talk, we want to go over some characteristic basic ventilation problems. Since a long time, we do know that positive pressure ventilation itself is able to injure the lung. And this term has been coined years ago, ventilator-induced lung injury. High tidal volumes, high distension pressures, cyclic collapse and reopening of alveoli, these are all mechanisms that result in a deterioration of the alveocapillary membrane, as you can see here in the electron microscopic images on the left side. On the right side, you see what this means in the histopathologic findings. You find an increased extravascular lung water. You find a high lung weight in these lungs, and you also find an interstitial albumin distribution. And in the macroscopic view, you find, well, very wet and heavy lungs, which has an enriched interstitium with albumin and blood. And this is related to positive pressure ventilation with high distension pressures. The physiological consequences of ventilator-induced lung injury has been nicely summarized by Orslatsky and Marco Ranieri some years ago. Ventilation at low lung volume may lead to atelectasis trauma by cyclic closing and reopening of the lung. On the other hand, ventilation at high lung volume may lead to overdistension and barotrauma. The structural consequences are various, and they include an increased alveolar capillary permeability, an increasing pulmonary edema, surfactant dysfunction, and in later stages, fibroproliferation of the lung. The biological alterations that cause this lung injury, they are various. And it is not only limited to effects on the lung, but also to systemic effects. Transmitted by mechanical damage like high shear forces, overstretching, cyclic stretching, and high intrathoracic pressures, the mechanical force is transmitted in a biochemical damage via the induction of cytokines, complement pathway, and a lot of other mechanisms. These disturbances are not limited to the lung, but are transmitted via inflammatory cells to other peripheral organs. And at the end of the story, this has the clear potential, or positive pressure ventilation has the clear potential to induce multiple organ dysfunction syndrome in the patient. And what is clear from what I said is that mechanical ventilation per se has the potential to injure the lung. However, in the already injured lung, as we have the situation in RDS patients, the lung is even more susceptible to further injury by mechanical ventilation. So it is one of the major goals of mechanical ventilation in these patients to avoid mechanical forces that do injure the lung. And if you look on setting the ventilator, we know some parameters. How can we reach this goal? For example, it is very much clear that using low tidal volume ventilation in these patients is protective to the injured lung because it prevents overdistension of lung areas. And we also very well know that the adequate positive and expiratory pressure level that prevents de-recruitment and tidal recruitment is also protective to the lung. So these are some parameters that we want to look up. So in practice, setting the ventilator does mean, first of all, to choose a tidal volume. And you have two different options to do this. The first one, if you ventilate in a volume regulated mode, well, you just choose the tidal volume by turning the knob. The second option would be if you ventilate in a pressure controlled mode, you set an adequate low pressure level, which is the Peep, and an adequate high pressure level, which is the plateau pressure. And according to the respiratory compliance of the system, from this setting, a specific tidal volume will result, and you have to control for this. The next step you go is setting the right pressure levels. First of all, the positive and expiratory pressure, and then the plateau pressure. And from the difference of the plateau pressure minus Peep level, the driving pressure is resulting. And we know from the last years that this is an important parameter also, because it's able to set up the pressure differences in relation to the respiratory compliance of the system, as you can see here by the formula. What you see here of the lung, which is reflecting the compliance of the system. And what you can see here is in the lower pressure levels, you need quite high pressure differences to gain volume. And from a certain time point, well, you need less pressure differences to create or to increase tidal volume. And if you think about lung protective ventilation, you want to ventilate the patient in this area of compliance. And the inclination of the graph is again decreasing. At the moment you reach the area of hyperinflation, meaning at this time you have high pressure differences that generate only low volume differences. And if you transfer this to the lung, you have in the lung, you have areas with a normal or a good compliance, you have areas with an impaired compliance, and you have areas with complete consolidation where we hardly open the lung with normal pressure, ventilation pressures. And it is clear that the given volume to the patient is first of all distributing in the areas with a good compliance, and afterwards may aerate the areas with the worst compliance. In total, this is leading on the one hand to persistent atelectasis, where you are not able to open the lung with positive pressure ventilation, and on the other hand you have areas where you hyperinflate normal lung areas, which would mean that you again have the risk to create ventilator-induced lung injury in these areas. If we consider the benefit of low tidal volume ventilation, we clearly know from a study nearly 20 years ago that low tidal volume, meaning in this study tidal volumes lower than 6 milliliter of kilogram standardized body weight in RDS patients, is leading to a better survival when you compare this group to a group that has been ventilated with high tidal volumes from 12 milliliters per kilogram standardized body weight. And since then we have a clear and internationally strong recommendation that patients with RDS should be ventilated with low tidal volume of lower or equal than 6 milliliters of kilogram standardized body weight. Since lung volume is related to height and not to body weight, tidal volume of 6 milliliters per kilogram standardized body weight is calculating considering predicted body weight and not measured body weight. This is a very important point. But from what I said, you will understand that 6 milliliters of kilogram predicted body weight of tidal volume is not equally sufficient in terms of lung protection for every patient. As you can see here, this patient has left the quite high functional residual capacity, whereas in this patient the FRC is markedly reduced. So the remaining volume, where the 6 milliliter of kilogram predicted body weight tidal volume distributes, is smaller in this lung, leading to hyperinflation, as is shown here in the CT scan and shown here by these red dots that indicate areas of hyperinflation. In this patient here, with the lung with a higher compliance, you don't have this over distended areas. So we have to learn and have to take into account that ventilation with 6 milliliters predicted body weight is not in every patient lung protective at the same level. However, clear is, as a surrogate parameter, it is a clear recommendation to ventilate these patients, RDS patients, with tidal volume equal or lower than 6 milliliter of kilogram predicted body weight. But as I said in the beginning of my talk, you also have the relation of lung injury by ventilation in non-injured lungs, in non-RDS patients. And also here it clearly could be shown that high tidal volume in terms of development of lung injury or in terms of development of mortality is or may harm the primary healthy lung. This is clear. So also in non-RDS patients, we want to ventilate with low tidal volume. However, it is not that easy to define what low tidal volume would mean in these patients. There's quite a nice study from 2018 investigating 475 against 480 patients comparing tidal volume ventilation of 6 milliliters predicted body weight with tidal volume ventilations of 10 milliliters predicted body weight in non-RDS patients. And it was clear that RDS was an exclusion criteria for this study. You can see here in the ventilation parameter that tidal volume and driving pressure, I come to that further on in my talk, tidal volume and driving pressure was significantly different in between those two groups. On the one hand, ventilating with 6 milliliters, on the other hand, ventilating in the medium with 9.8 milliliters. What did this mean for the respiratory situation of the patient? Well, as you can see here from the surviving curve and from the primary endpoint free from invasive ventilation, it didn't do any difference to these two groups. So ventilation with intermediate tidal volume of 10 milliliter in patient with non-RDS was not inferior to ventilation with low tidal volume of 6 milliliters per kilogram predicted body weight regarding these two parameters. So in these two patients, you will be somewhere in between in choosing the height of the tidal volume, and it may be justified in this patient to ventilate with higher than 6 milliliters of predicted body weight tidal volume, just for example to avoid development of hypercapnia. Going further on to the definition and to the right setting of the PEEP, now the situation is getting more difficult. What we do know is that patients with RDS, they will benefit from high PEEP values, whereas patients without RDS, they do not benefit that much. And here on the right side, you see clearly at the moment when the patients benefit with respect to increasing PF ratio to the increase of PEEP, this situation was associated with a decreasing probability of death. This is shown here in the violet curve. However, up to now, it is not clearly defined what is high PEEP and what is low PEEP, and to what PEEP value should we adjust our ventilator. This is much more difficult than with respect or compared to the situation with tidal volume. But we have some instruments that help us to set the PEEP. This is the PEEP FiO2 table. This is an empiric situation, an empiric table, which sets the given PEEP into the relationship to the applied FiO2. And we have different PEEP tables, the low PEEP table and the high PEEP table within the literature. And they have been compared years ago in several studies. And from these studies, we do know that patients with RDS with severe RDS, they profit from the high PEEP table, which is just different to the low PEEP table, especially in the lower region of the FiO2. As you can see here, the given PEEP with respect to the given FiO2 is much higher in the high PEEP table at an FiO2 from 0.4 to 0.8 than in the group that received or that were treated with the low PEEP table. At the end of the PEEP table, by an FiO2 of 1.0, these PEEP levels are more or less the same. There are more sophisticated methods to guide the PEEP according to the individual situation of the patients. For example, by using specific catheters that measure the esophageal pressure, and therefore from these data, from these measurements, we get an idea how to set the PEEP. I don't want to go in detail regarding this method. This is beyond the scope of this study. However, I show you this data because we have a very nice study that compared these both methods, the empiric setting the PEEP according to the empiric high PEEP table, compared to setting the PEEP according to a more physiologic and individualized approach of measuring the transesophageal pressure. If you look on the results, and this is clearly shown here, the set PEEP at the end, as you can see here, over time there's no difference. There's no difference according to the reach plateau pressure, and there's also no difference regarding regarding the driving pressure. So, and if you then look on the endpoint of the study, you see that the primary endpoint probability of survival after 60 days, and this is quite logic, was not different in between these groups because there was no difference in setting the PEEP. On the other hand, you can say using the empirical PEEP FiO2 table, by using this table, you get quite near to the physiologic situation, which is better reflected by setting the PEEP using transesophageal pressure. For the practical situation, this clearly means it is a quite good instrument to set the PEEP using the PEEP FiO2 table. You already is reflecting the compliance of the lung. Again, there's another parameter which is very important to set up a lung protective ventilation, and this is the driving pressure. The driving pressure is the delta of the plateau pressure minus the PEEP level. And the driving pressure is defined by the tidal volume which is generated in relation to the individual compliance of the respiratory system. And with the driving pressure, I have an instrument that intrinsically normalizes the tidal volume to the functional lung size. This is interesting. And if you then look on the data we have here, these are post hoc analysis of multiple randomized studies, and just look on this side. At the moment, you ventilate the patient first of all with a sufficient PEEP. At the moment, you make a limitation of the plateau pressure, which at the end would mean, well, you have a small delta P, delta pressure, a small driving pressure. If you set the ventilation in like shown here, this situation is associated with the best reduction in mortality in this patient. So these are data from post hoc analysis. There's no randomized study controlling for this, but from all these data, it is a strong signal that driving pressure, setting the right driving pressure is important to decrease the impact of ventilator-induced lung injury. And for the driving pressure, again, we have a marker where we should set the driving pressure because it's clearly shown that the driving pressure equal or below 14 centimeters of water was associated with an increased survival of the patient. So keep this in mind. Driving pressure, setting and looking for the driving pressure should be below or equal 14 centimeters of water.
I now want to discuss the specific situation in ventilating COVID patients. We have different treatments in different phenotypes. As you can see here on the left side, in some patients you don't have significant atelectasis or significant infiltration in the lung. And in these types of the lung, they are often characterized through a low elastance, which means a high compliance, a low ventilation to perfusion rate, a low lung weight, and a low recruitability, because there are not so many areas that has been closed by infiltration, for example. This type is coined the L type. On the other hand, we have another type, which more looks like the classical type of RDS, with completely consolidation in the basal areas of the lungs, with intermediate areas, and with small areas in this case with quite normal lungs, and also significant hypoxemia. This type maybe is characterized by a high elastance, which means a low compliance, a high right to left shunt, a high lung weight. And you now have to consider what would be the right option to ventilate in these different clinical situations. Setting the Peep value could mean it is quite reasonable not to choose too high Peep values or to use the low Peep table, because you don't have these consolidation in these basal areas, and you may run in the situation that you produce hyperinflation, although in this area, although you may not have the situation of tidal de-recruitment and recruitment using low Peep table. I'm pretty much clear that we also should ventilate these patients with low tidal volume, because we have a pre-injured lung, and as we do know, the pre-injured lung will suffer from high tidal volume ventilation. So tidal volume of 6 milliliters per kilogram standardized body weight or below should be set in these patients. It is an individual decision whether you turn these patients in prone positioning. We do know from the literature that also patients in this situation did benefit from prone positioning. Well, for the H type here, the classical situation using high Peep table for preventing further consolidation, and using low tidal volume for preventing hyperinflation and have the correct ventilation for this area of the lung. And also proning. This is quite clear that this is a classical RDS situation, and patients should in terms of ventilating these patients, we should look for high PEEP table, low tidal volume, and also proning. The clinical difficult situation that the patient may change from this situation into this situation, and this is what we want to prevent, because it's clear that this is a more severe ill patient. So on a daily basis, we really have to revalidate, do we have sufficient PEEP, or do we have to increase PEEP because of infiltration are increasing and we may have basal consolidation. And again, we also have to rethink about when at the right time point to put these patients.
I want to come to another important issue regarding lung protective ventilation. And this is when and how to allow assisted spontaneous breathing in these patients. From the physiological point of view, there are clear advantages if you allow spontaneous breathing, meaning improved ventilation perfusion ratio, improvement of oxygenation, reduction of atelectasis, and reduction of sedatives. And with respect to respiratory muscles, it has been clearly shown in other contexts that immobilization of the diaphragm by controlled mechanical ventilation is leading to a massive and very fast muscular atrophy, which is beginning within the first hours of controlled mechanical ventilation. This also is a clear argument for maintenance of assisted spontaneous breathing. However, when looking in the literature, we have to say of spontaneous breathing. And what we clearly do know from experimental settings in animals is that allowance of high respiratory frequency, of high respiratory drive, results in high distension pressures, as been shown here, and in high transesophageal pressure differences, as indicated here, which then lead in the following situation to an increase of lung injury, an increase of inflammatory situation in the lungs. So high spontaneous breathing efforts in lung failures clearly has the potential to worsen lung injury. And this is a clear disadvantage of spontaneous breathing. In the last years, there's a term that has been coined to just address this issue. High driving pressure in the patient, high respiratory drive is leading to self-inflicted lung injury in terms of increase of an inflammatory situation, in terms of diaphragmatic injury, in terms of also development of asynchronias. That has been clearly shown and has been clearly hypothesized, and from the animal studies there's a clear signal that this is a situation that may happen. So there are open questions, clear open questions. When should we start to allow spontaneous breathing? At which pressure level should we allow to spontaneous breathing, assist spontaneous breathing? And there's another issue that clearly shows at the moment the patient ventilates or breathes with a very high respiratory drive, it is hardly possible to control for low tidal volume. These are all arguments that clearly show that assisted spontaneous breathing to some extent should be controlled in these, especially in the early course of RDS patients.
It has been discussed over the last 10 years whether control of spontaneous breathing by neuromuscular blocking agent would improve the outcome situation in RDS patients. There is a big study from 2019, a very well performed study, comparing 500 to 500 patients. In the intervention group, the patient received neuromuscular blocking agents within the first 48 hours, whereas in the control group by protocol not. And also in the intervention group, you can see that this patient group, especially during the first 48 hours, was much more deeply sedated. So a clinical situation which did control for spontaneous breathing. However, when you look on the outcome parameter, there's no difference regarding survival from hospital to discharge from hospital or regarding discharge to home in between these two groups. Also meaning that early neuromuscular blocking agents would not improve the. At the end of my talk, I want to point out some typical complications that you find in mechanical ventilation. It is very important to look on the ventilator and observe the curves you see on the ventilator. And as you can see here, this is the flow curve. Well, this is the inspiration situation. This is the time of expiration here, or better seen here. And if you follow this line, you see this line during end expiration. At the moment the next inspiration is beginning, this line does not come to zero. This does mean that there is some obstruction in the airway, and this also does mean that you somehow generate an airflow, that you somehow generate an intrinsic PEEP. This can be by bronchial secretion. This is common in chronic obstructive lung disease. And you can see in this example, at the moment you prolong the expiration time by decreasing the frequency, the patient has more time to exhale. And here you see the expiration curve is getting to zero through this management. However, you have to take into account that the minute ventilation is smaller in this at this moment. Another example of a typical pressure flow curve is in the situation when the lung is getting stiffer and stiffer, and you may have this situation at the moment you have a febrile proliferation of the lung. As you can see here, you have the inspiration hold for a certain time, and then the expiration. This is what the pressure does. But look on the flow. What's happening to the flow? On definitely what kind of inflow in the patient you have. The flow in the patient is significantly shorter during this inspiration time because of the stiffness of the lung, because of the significantly reduced compliance. And you can see this here, and you can see it here in the tidal volume, which can be generated by this pressure settings in these patients. So you also have to be aware of the development of the stiff lung, and it's clinically a quite difficult situation to ventilate or to adjust the ventilation correctly in this situation. because as you can imagine, at the moment you have low tidal volume, like 3.2 liters per minute, you are running into hypercapnia. I want to conclude my talk. In RDS patients, positive pressure ventilation with high distension pressures and cyclic collapsing of the alveoli may result in ventilator-induced lung injury. We do know that setting or adjusting the ventilation according to tidal volume, according to an adequate PEEP level, and limiting driving pressure has the impact to be lung protective during ventilation. We don't know to what extent assisted spontaneous breathing is of benefit in early RDS patients. But what we do know is that we should control for assisted spontaneous breathing during this phase of the disease. Expiratory flow obstruction, e.g. by secretion, and development of stiff lungs are typical constellations in ventilation of RDS patients and should be observed on the monitor of the ventilator. I thank you for your attention.